Tomosynthesis is different from standard mammography because it allows us to look at layers of breast tissue. The way tomosynthesis works is that the X-ray tube moves, and it moves in a short arc, and multiple very low-dose X-rays are obtained. And then that data, that digital data set, can be reconstructed and allow us to look at very thin sections or layers of the breast tissue. So what that allows us to do is all the breast tissue that's in front of or behind a breast cancer that might otherwise hide that cancer is no longer a problem.
In many ways, by allowing us to see through the breast at various small incremental levels, we're able to see if there's a really tiny small cancer that otherwise on a traditional two-dimensional mammogram could easily be overlooked.
It helps detect early breast cancers in patients with dense breasts, as well as decrease the false positives, which result in additional imaging and tests for women who sometimes can get quite frustrated with the additional cost and additional discomfort from additional compression imaging.
So what we're biopsying is actually more often now proving to be something of significance for patients, getting rid of a lot of the previous false alarms that many patients had encountered in the past.
When we do find something that's cancerous, the nice part about the tomographic images is that given that every image is acquired at 1 millimeter slice, we're able to find exactly where in the breast the lesion is, and then go to another modality such as ultrasound, which is much easier on the patient to find the lesion and biopsy the lesion through ultrasound versus other means, which include stereotactic biopsy, which is a little bit more time-consuming and more difficult for the patient.
We actually have a long history of breast imaging technology development at Dartmouth, and in particular, breast tomosynthesis. We were among the first to research the FDA-approved tomosynthesis technology, and were one of 5 institutions that contributed data that ultimately led to this approval.
We were the first hospital in the entire state of New Hampshire to use this technology back years ago. We benefited from the research that was performed up at Dartmouth Hitchcock Medical Center in Lebanon, and now it's being implemented in everyday clinical practice. It's great.
I think for the vast majority of patients, there really is no difference in their experience of having a tomosynthesis mammogram as opposed to a traditional mammogram. The breast is still in compression, there's still an X-ray exposure. The fact that the X-ray tube is moving, sometimes patients recognize that, sometimes they don't, but that's really the only difference to the patient experience. There is a small increase in radiation dose. It's about 2 months of background radiation. And that amount of dose in the big scheme is probably negligible. Another way to think about it is if you were to take a round-trip plane flight from New York City to Europe, you'd have about the same radiation exposure.
So we really, as physicians, have to try to balance the risks versus benefits. And it's much more beneficial to try to pick up a tiny cancer as opposed to worrying about a slight increase dose of radiation to the breast.
What I'm showing you here is a patient who had a recent tomosynthesis exam. So this is the traditional mammogram display, and within this you really don't see any abnormality. And these are just benign calcium deposits in the breast. So now I'm going to shift over to the tomosynthesis or 3D part of the exam. As we roll through here, we're going to go at 1 millimeter increments, and now we're paging through those 1 millimeter increments on both sides. And what's interesting in this case is now you can see this area that looks distorted. There's some lines radiating to this, which we couldn't see in the regular digital mammogram. And this is, in fact, a small breast cancer that was only visible on the 3D part of the exam. So this is the kind of benefit in cancer detection that we're hoping for.
We try to evaluate our patients based on their personal history. We evaluate them based on their risk factors using a risk assessment model, a personal history of the breast cancer, and we try to make this modality available to every patient to ensure that everyone has the equal opportunity to embrace this technology. But ultimately, we want to make sure that we screen the appropriate patients with the very dense and heterogeneously dense breast tissue, as this benefits them the most.
As a radiologist, I'm very interested in advances in imaging technology, particularly for breast imaging. Although I think there's a great take-home message for patients that breast health is really multifactorial. It's not just going for a yearly mammogram. It's also having a monthly breast self-exam performed, as well as having a yearly clinical breast exam. I often tell my patients that nobody knows their breast better than them. So if they were to feel a lump or a bump that's new, or notice some change in their breast self-exam, even if they just had a normal routine screening mammography exam, they really need to bring that concern up to their doctor so that we can further evaluate it.